If you take amlodipine or losartan every morning, how clearly has anyone ever explained to you what to watch for while you're on it? Most people pause at that question, and that pause is worth paying attention to. Because these are not obscure medications. Amlodipine and losartan are two of the most widely prescribed blood pressure drugs in the world. Tens of millions of people take one or both of them every single day. And they work. They reduce heart attack risk. They protect the kidneys. They keep blood pressure in a range the body can manage. But they also do things to your body that your doctor may never have had time to explain in a 12-minute visit. And some of those things, if you do not know what to look for, can be mistaken for aging, for stress, for something unrelated. They can quietly go unaddressed for months. That is not a failure of medicine. It is a failure of information. Today, we are fixing that. Here are 7 signs that if you are on either of these medications, you should know and know what to do about. Before we go further, a quick and important note. This channel is for general education. I am not your doctor, and nothing here is medical advice, a diagnosis, or a prescription. I explain the science behind what these medications do inside your body, the why that often gets skipped. Before you change anything about your treatment, talk with your own doctor or pharmacist. That conversation matters. What I can give you today is something many people on these medications have never received. A plain language explanation of what these drugs actually do, and the 7 signs, the research, and the prescribing. Guidelines say you should never dismiss. 7 specific things to watch for, ranked by urgency, starting with the ones that are manageable, and working toward the one that requires immediate action. Stay with me to the end, because the number 1 sign is the one almost no one knows about. Stay with me to sign number 1. Because the warning sign at the top of this list involves swelling, but not the kind most people think of. It can come on within hours, it can progress to your airway, and it is a medical emergency that requires calling for help immediately, not a call to your doctor's office in the morning. I want you to know what it looks like before it happens to you, and watch for sign number 4. It is something that millions of people on amlodipine notice in the bathroom mirror every morning and never connect to their medication. Before we start, tell me in the comments, are you on amlodipine, losartan, or both? And how long have you been taking them? I read every comment, and your answers shape what I cover next. You might be surprised how many people watching right now are on the exact same combination you are. Type it below while this plays. Here is what almost no one explains. What these 2 drugs actually do, and why they do it differently. Amlodipine is a calcium channel blocker. Calcium is what tells the smooth muscle around your blood vessels to contract, to squeeze tight. Amlodipine blocks that signal. The muscles around your blood vessels relax, the vessels widen. Blood flows through with less resistance, and the pressure drops. Think of it like loosening the grip on a garden hose. The water flows more freely, and the pressure inside the hose drops. Losartan works through a completely different system. Your body produces a hormone called angiotensin II, one of its most powerful blood pressure-raising signals. Angiotensin II tells blood vessels to constrict. It tells the kidneys to hold on to sodium and water, which raises blood volume and pressure. Further, losartan blocks the receptor that angiotensin II binds to. The signal never lands. The vessels stay relaxed. The kidneys release more sodium and water. Pressure drops. 2 different mechanisms. 2 different sets of side effects. 2 different things to watch for, which is exactly why understanding which of your simple toms belong to which drug matters. Not all warning signs on this list apply to both, and knowing which drug is doing what gives you and your doctor the right information to act on. The important thing to understand is this. Both of these medications change the way your body manages pressure, fluid, and blood flow throughout your entire system. Not just in your arteries, in your kidneys, your legs, your heart, your gums, and your face. The 7 signs we are about to cover are not random side effects. Every single one of them is the body telling you something about what is happening in one of those systems. And once you understand the mechanism, the sign makes complete sense. Warning sign number 7. Swollen ankles, feet, or lower legs. Drug. Amlodipine vertical bar 6-beat template. Name. Frame vertical bar. Mechanism vertical bar. Analogy vertical bar. Evidence vertical bar. Prescription vertical bar. Bridge. Most common side effect of amlodipine affects roughly 1 in 10 patients and is frequently dismissed as just aging. If you are on amlodipine and your ankles or lower legs have started to look or feel puffier than they used to, that is the medication, and it is worth addressing. It is the most common side effect reported with this drug, and it is one that millions of people quietly tolerate for months or years because no one told them it was connected to their pill. Mechanism. Amlodipine relaxes the walls of blood vessels, including the small capillaries in your legs and feet. When those vessel walls relax more than the body expects, fluid leaks out of the capillaries and into the surrounding tissue. The result is swelling. It is not related to your heart failing to pump, and it is not a sign of kidney disease, though both of those can also cause leg swelling, which is exactly why this needs to be evaluated and not assumed. It is a direct consequence of the drug's vasodilating effect on peripheral blood vessels. Analogy. Think of your capillaries as pipes that are usually kept at a certain pressure. When amlodipine relaxes the walls, the pressure inside drops and fluid seeps through the walls into the surrounding tissue, the way a slightly leaky pipe leaves moisture on the outside of the pipe, not just inside it. Evidence. The FDA-approved prescribing label for amlodipine lists peripheral edema, swelling in the limbs at an incidence of approximately 10.8% of patients in clinical trials, making it the most commonly reported side effect of the drug. Research published in the American Journal of Cardiology has confirmed it is a dose-dependent effect. Higher doses, more swelling. Prescription education only. If the swelling is significant, uncomfortable, or worsening, bring it up at your next appointment. Do not stop your medication. There are options: a lower dose, a different calcium channel blocker, or a combination approach. But the first step is simply telling your doctor it is happening. Because many patients never do. Bridge. The next sign is connected to the same mechanism, amlodipine's effect on blood flow, but it shows up somewhere very different and is even less frequently discussed. Warning sign number 6, persistent headaches or a flushed, warm face. Headaches and a warm, flushed feeling in the face, particularly in the first weeks on amlodipine, or after a dose increase. Easy to attribute to stress, to the weather, to blood pressure itself. But if you are on amlodipine and these started around the same time as your prescription, there is a very specific reason. Mechanism. When amlodipine relaxes blood vessel walls throughout the body, it does not do so evenly. The blood vessels closest to the surface of the skin, particularly in the face and scalp, dilate. Blood flow to the skin increases. The result is warmth, redness, and sometimes a throbbing headache as the vessels in and around the scalp expand and pulse with more blood than usual. This is not a sign that your blood pressure is rising. In some cases, it is the opposite. It is the drug working so efficiently on peripheral vessels that the body sends more blood to the face. Analogy. Think of the face as a radiator. When amlodipine opens up the vessels, more warm blood flows to the surface to release heat. The radiator gets warmer, redder, and the increased pressure through the vessels nearby can produce a dull throb at the temples. Evidence. The FDA prescribing label for amlodipine reports headache in approximately 7.3% of patients and flushing in 2.6%, making them among the most commonly reported side effects in clinical trials. Both effects are recognized as pharmacodynamic responses to the drug's vasodilating action on peripheral blood vessels. Prescription education only. Headaches and flushing that begin when you start amlodipine often decrease over the first few weeks as the body adjusts. If they persist, are severe, or are accompanied by vision changes, tell your doctor. A severe headache in someone with high blood pressure always warrants evaluation. Do not assume it is just the medication. The bridge. Now we move to a warning sign that affects both amlodipine and Losartan users, and one that is a leading cause of a preventable injury in people over 60. Warning sign number 5, dizziness, lightheadedness, or near fainting when you stand up. This is the most underappreciated fall risk in all of senior medicine, and it is directly linked to blood pressure medication. You stand up from a chair or a bed for a few seconds, maybe longer, the room tilts. Your vision dims at the edges, your legs feel uncertain. You reach for something to steady yourself, or you don't, and you fall. If this is happening to you, it has a name: orthostatic hypotension. And if you are on a blood pressure medication, your medication may be a direct cause. Mechanism. When you stand up, gravity pulls blood toward your lower body. Your circulatory system normally compensates within seconds. The heart speeds up, the vessels tighten, and blood is pushed back up to the brain. But both amlodipine and Losartan are designed to relax blood vessels and reduce that tightening response. In an older body, where that compensatory reflex is already slower. The combination can mean blood pressure drops faster than the system can correct, and for those few seconds, the brain receives less blood than it needs. The result is dizziness, graying vision, or actual fainting. Analogy: think of it as a pressure management system that was calibrated for a certain load. Standing up changes the load suddenly. In a younger body, the system recalibrates in 2 seconds. In a system that has been deliberately relaxed by medication, the recalibration is slower, and in those extra seconds, the brain notices. Evidence: a study published in the New England Journal of Medicine by Tanetti and colleagues found that intensification of antihypertensive treatment, meaning adding or increasing blood pressure medications, was associated with a 40% higher risk of serious fall injury in older adults. The American Geriatric Society's Beers criteria explicitly flags orthostatic hypotension as a major risk in adults 65 and older taking antihypertensives, and recommends routine assessment for this effect. Prescription education only. If this is happening to you, tell your doctor. Do not stop your medication on your own. The risk of uncontrolled blood pressure is real, but this is a solvable problem. Dose timing, hydration, the speed at which you rise, the position you start from. These are all adjustable. Rise slowly. Pause with your feet on the floor before you stand. Use a stable surface to push from, and bring up the dizziness with your prescribing doctor, because there may be a medication adjustment that eliminates it. Bridge. The next warning sign is one that catches people completely by surprise, because they notice it in the mirror every morning and have never once connected it to the pill they take at night. Warning sign number 4. Gum swelling, tenderness, or unusual bleeding. This is the one most people on amlodipine never hear about until they are already sitting in a dentist's chair. Amlodipine belongs to a class of calcium channel blockers called dihydropyridines. One of the documented side effects of this class, affecting roughly 2 to 5% of users, is gingival hyperplasia. That is a clinical term for gum tissue overgrowth. The gums become enlarged, sometimes tender, sometimes prone to bleeding. It can be subtle at first, a slight puffiness around the base of the teeth, a little more bleeding when you brush. Over months, it can become significant enough to affect the fit of dental work and the health of the teeth underneath. Mechanism: calcium plays a role in the regulation of gum tissue cells, specifically in how they break down and renew. Calcium channel blockade disrupts that regulation. In some patients, the gum tissue cells proliferate faster than they are cleared. The result is an overgrowth of otherwise normal tissue. It is not a sign of gum disease in the infectious sense. No bacteria are primarily responsible. It is a direct cellular response to the drug's mechanism. Analogy: think of your gum tissue like a garden that self-trims. Calcium signals are part of what keeps the growth in check. Block that signal long enough in susceptible tissue, and the garden starts to overgrow. Not because something is wrong with the soil, but because the trimming signal has been interrupted. Evidence: research by Seymour and Thomason, published in the Journal of Clinical Periodontology, established gingival hyperplasia as a recognized class effect of dihydropyridine, calcium channel blockers, including amlodipine, with a prevalence estimated between 2 and 5% of users. Importantly, the condition is generally reversible when the medication is changed or the dose is reduced. The tissue typically returns to normal within months. Prescription education only. If you are on amlodipine and your gums look different than they used to, puffy, enlarged, or more prone to bleeding, tell both your prescribing doctor and your dentist. This is worth documenting. And importantly, do not assume it is a dental hygiene problem and start brushing harder. The cause is systemic, not local. The conversation with your doctor may lead to a dose adjustment or a medication switch that resolves it entirely. Bridge. Sign number 3 is something people feel, not see, and it comes from the same vasodilation mechanism. But this time, the body's response to it creates a sensation that can be alarming if you do not know what it is. Warning sign number 3, a racing, pounding, or irregular heartbeat. Your heart suddenly beats faster than expected, not during exercise, just sitting. This is one that sends people straight to an emergency room, and in many cases, it is the medication working exactly as designed, but triggering an effect the body was not prepared for. Amlodipine relaxes blood vessel walls throughout the body. Blood pressure drops, and the body, specifically the nervous system, detects that drop and responds by sending a signal to the heart: speed up. maintain output, keep blood moving. In some patients, that compensatory response called reflex tachycardia becomes noticeable. The heart beats faster or harder than usual. There may be a feeling of fluttering or pounding in the chest. There may be a sense that the heart is working harder. Mechanism. This is the body's baroreceptor reflex at work. Baroreceptors are pressure sensors in your arteries that monitor blood pressure moment to moment. When amlodipine causes a drop in peripheral resistance, because the vessels have relaxed, baroreceptors signal the sympathetic nervous system to increase heart rate and contractile force to compensate. In most people, this response is subtle. In some, particularly in the early weeks of treatment or after a dose increase, it becomes perceptible. Analogy: for thin K of it as a pump connected to a pressure sensor. The pump is set to maintain a certain pressure in the system. When the pipes relax and pressure drops, the sensor tells the pump to work harder. The pump speeds up. You feel the pump speed up. Evidence. Reflex tachycardia is a well-documented pharmacodynamic effect of dihydropyridine, calcium channel blockers, established in the pharmacological literature by Abernethy and Schwartz in their foundational NEJM review of calcium. Antagonist pharmacology. The FDA prescribing label for amlodipine includes palpitations in its listed adverse reactions. The effect is generally self-limiting and often resolves as the body adjusts to the medication. Prescription education only. Palpitations in anyone over 60 always warrant a conversation with your doctor, not because they are necessarily dangerous in the context of this medication, but because palpitations have many causes, and the right evaluation rules out the ones that do need attention. Do not simply assume it is the amlodipine and ignore it. Tell your doctor when it started and what it feels like. If you ever experience chest pain, pressure, or shortness of breath alongside a racing heart, that is a different conversation, and it requires immediate medical evaluation. The bridge. Now we move from amlodipine's effects to a warning sign, specific to Losartan, one that involves a mineral you may never have thought to have tested, and that can quietly build to dangerous levels in your blood. Warning sign number 2, unusual muscle weakness, cramping, or fatigue, especially combined with reduced urination. This one requires you to pay attention to 2 symptoms at once. Either one alone could mean many things. Together, they point to something specific, and it needs attention. Losartan works by blocking angiotensin II, the hormone that tells your kidneys to hold on to sodium. One of the downstream effects of that blockade is that the kidneys retain more potassium. For most people, this stays within normal limits. But for people who are also taking potassium supplements, who have reduced kidney function, or who are on other medications that raise potassium, the levels can climb. The condition is called hyperkalemia. Excess potassium in the blood, and the body signals it in a specific way. Mechanism. Potassium is the mineral that governs electrical signaling in muscle cells, including the heart. When potassium levels rise above the normal range, muscle cells become less excitable. The signal that triggers a contraction becomes harder to produce. Muscles that normally fire on demand start to feel heavy, tired, or crampy. In the legs, this can feel like unusual fatigue after very little activity. In the hands or arms, it may feel like weakness. And because the kidneys are working harder to manage the potassium buildup, urine output may decrease. These 2 symptoms together, muscle heaviness and less frequent urination, are a signal worth taking seriously. Analogy. Think of your muscles as a lighting system that runs on the precise balance of electricity. Potassium is the circuit regulator. When potassium rises too high, it is like too much current flooding the circuit. The lights don't get brighter, they flicker, and eventually the circuit becomes unreliable. The muscles don't work the way they should. Evidence. Research by Palmer, published in the New England Journal of Medicine, established that ARBs, including Losartan, are associated with hyperkalemia, particularly in patients with reduced kidney function, diabetes, or concurrent use of potassium-raising medications. A review by Horn and Zietze in the Journal of the American Society of Nephrology confirmed that hyperkalemia from RAA's blocking medications is underdiagnosed in clinical practice, particularly in older adults whose kidney filtration is already reduced by age. Prescription education only. If you are on Losartan and you notice unusual muscle fatigue or heaviness, appears in cardiology and emergency medicine literature with quiet regularity. Arthur had been on lisinopril for his blood pressure for several years. His doctor switched him to Losartan after he developed a persistent dry cough, a known common side effect of ACE inhibitors. The switch made sense. Losartan carries far less risk of that particular side effect. He felt better. The cough stopped. He settled into the new medication without difficulty. 8 months later, Arthur woke in the night with a sense that his lips felt thick. His tongue felt slightly heavy. He dismissed it and went back to sleep. By morning, his lower lip had swollen noticeably, and there was a tightening sensation at the back of his throat that he found difficult to describe. He called his son. His son drove him to the emergency room. In the ER, the team recognized angioedema. They treated him appropriately, and he recovered without lasting harm. What came out in the conversation afterward, no one had told him that angioedema, the reaction that had never happened on lisinopril, was still a possibility on Losartan. He had not known what to watch for. He had not known that waking up with swollen lips was not something to sleep off. He was fortunate. The swelling progressed slowly enough that he had time. Not all cases give that window. The knowledge Arthur needed was simple. It was the kind of information that takes 4 minutes to explain in a doctor's office, and that makes the difference between a managed emergency and an unmanaged one. That 4-minute conversation is what this video is. Here is what all 7 of these signs share. None of them are signs that the medication is failing. Most of them are signs that the medication is working, and that the body is responding in a way that needs to be known, monitored, and in some cases, adjusted. Peripheral edema, flushing, dizziness, gum changes, palpitations. These are not signals to stop your medication. They are signals to start a conversation. The one exception is angioedema. That is the one sign that does not wait for a conversation. That is the one where you call for help first. For everything else tonight, you can do 3 things. First, think about whether any of these 7 signs sound familiar. Not just do I have swollen ankles, but when did that start? And did it start around the same time as my prescription? The timeline is information. Write it down. Second, at your next appointment, bring your complete medication list. Everything you take, including supplements and over-the-counter medications, and ask your doctor directly. Are any of these signs something I should watch for on my specific medication? Give them the chance to explain what your prescribing information already says. Third, ask your pharmacist for a medication review. You do not need an appointment. You do not need a referral. A pharmacist can walk through your medication list, flag interactions, and explain what each drug is known to do. That conversation is free. It is available at most pharmacies today. And please do not stop Amlodipine or Losartan. Based on this video, these medications protect against strokes. They protect your kidneys. They extend life. The goal of this conversation is not alarm, it is awareness. Awareness makes you a better advocate in the conversations that follow. Now I want to hear from you. Which of these 7 signs have you noticed or noticed in someone you care about? Tell me in the comments, and while you are there, type the word timing if you have ever been told it matters what time of day you take your blood pressure medication. Because it does, and very few people know why. If this helped you today, send it to someone on a blood pressure medication. One share may mean someone knows what swollen lips mean before it happens to them. And next, because you now understand what these 2 drugs do inside your body, the question that comes up naturally is, are you taking them at the right time of day? The research on antihypertensive timing, morning versus evening, has shifted in the last several years, and the implications are real. There is a specific video on that topic next in the queue. Watch it before your next morning routine, especially alongside less frequent urination. Bring this to your doctor's attention and ask whether a recent blood test has checked your potassium and kidney function. A simple blood panel answers this question definitively. Do not stop your medication on your own. The risk of hyperkalemia is manageable with monitoring. The risk of untreated high blood pressure is not. Bridge. And now number 1. The warning sign that is not about discomfort, not about something that develops over weeks. This is the sign that requires immediate action, and almost no one on Losartan has ever been told to watch for it. Warning sign number 1. Any swelling of the face, lips, tongue, or throat. This is the warning sign I need you to remember above all others, because the window between this is strange and this is an emergency can be very short. Angioedema is a rapid, deep tissue swelling beneath the surface of the skin, in the tissues of the face, lips, tongue, throat, or airway. It is not the same as the ankle swelling from amlodipine. Ankle swelling develops slowly, is visible on the surface, and causes no immediate danger. Angioedema is different. It can develop within hours of a trigger, it can affect the airway, and when it does, breathing becomes difficult, fast. Most people associate angioedema with ACE inhibitors, medications like lisinopril. And they are right. ACE inhibitors carry a higher risk of this reaction. But Losartan is an ARB, a different class, and ARBs, including Losartan, can also cause angioedema. The risk is lower, but it is real. And for patients who previously experienced angioedema on an ACE inhibitor and were switched to Losartan as an alternative, the risk is meaningfully higher than the general population would expect. Mechanism: the renin-angiotensin system, the system both ACE inhibitors and ARBs affect, plays a role in regulating a compound called bradykinin. Bradykinin, when it accumulates, promotes vasodilation and vessel permeability in deep tissue. That permeability is what causes angioedema, fluid rushing into the soft tissues of the face and airway, driven by vessels that have become suddenly more permeable than normal. The swelling can worsen rapidly because the same mechanism that caused it continues to drive it. Analogy: think of the blood vessels in your face and throat as normally well-sealed containers. Angioedema is what happens when those seals are suddenly compromised. Fluid floods in from all sides at once. Once the seals open, more fluid keeps entering until the trigger is removed and the system resets. In a narrow space like the throat, that incoming flood has nowhere to go but inward. Evidence: research by Haymore and colleagues, published in Annals of Allergy, Asthma, and Immunology, found that ARB-associated angioedema occurs at an estimated incidence of 0.1 to 0.7% of users, lower than ACE inhibitors, but not absent. The FDA prescribing label for Losartan includes a specific warning for angioedema and notes that patients with a history of ACE inhibitor-associated angioedema may be at higher risk when switched to an ARB prescription. This is the sign that does not wait for a doctor's appointment. If you or someone you care about experiences sudden swelling of the face, lips, tongue, or throat while on Losartan or any ARB, this is an emergency. Call emergency services immediately. Do not wait to see if it gets better. Do not drive yourself to urgent care. This is a situation where minutes matter. Throat swelling can progress to airway closure. Call for help first. If the swelling is only on your face or lips, without throat involvement, without difficulty swallowing or speaking, that is still a same-day call to your doctor. Describe the swelling, when it started, and where. Stop your medication only on your doctor's instruction, but do not dismiss it and do not wait. Consider a man in his early 70s. Call him Arthur, a composite of the kind of case that